I am Susan Hay-Patrick on the board of City Club Missoula and also chair of our forum committee, filling in for our board president, Jim Royan, who is not here today. So welcome on behalf of our board to City Club Missoula. Before we get started with our two terrific speakers for today, obviously September 11 is a date that is etched indelibly on our American conscience and something that we think about all the time, but especially on September 11. So please join me in a moment of silence before we get started. Thank you. So City Club Missoula, as many of you know, because many of you are our regular attendees, we meet the second Monday of the month to learn about and discuss issues of interest to our community and often to our state, our nation, our world. I'll talk a little bit in a minute about our format. But certainly, I think we would all agree that healthcare and the changing landscape of healthcare qualifies as an issue of interest to our country and certainly to those of us in Missoula. We had a PowerPoint running earlier that listed our sponsors, the wonderful organizations and businesses that make possible our City Club forums. If you are interested in becoming a sponsor, please speak to me or any one of our board members, and I see several of them in the crowd, so please raise your hand if you're a member of the City Club board. Okay, so any of those folks can tell you about City Club sponsorship, and we really work hard to find programs of interest and that are compelling for you, and we welcome your suggestions as well. So, our format at City Club, we're going to hear from our two speakers, and this is a unique City Club component. We then break about 12:30 for 10 minutes, and each table, you introduce yourselves to the folks at your table, and then each table formulates a question. And sometimes we remind you that we really mean a question and not a statement. And that this is an opportunity to find common ground with people of differing viewpoints on these compelling issues at City Club. So we'll hear from our two speakers, then take a break, and then you'll formulate your questions, and then John Rettenmeyer, our former board member and keeper of the microphone, will circulate, and each table has an opportunity to ask a question, and we break promptly at 1. So. In order of speaking, I'm not sure how they decided this, but first we're going to hear from Dr. Samer Khodor, who is the Chief Physician Executive for Ambulatory Care at Providence St. Patrick Hospital. He's been there for just over a year, coming to St. Pat's from Kaiser Permanente in Colorado, where he served in multiple physician leadership roles for 11 years. He's a board-certified internal medicine physician with a lot of experience in private practice and as part of a multi-specialty physician group. He has a lot of experience collaborating with doctors, nurses, pharmacists, hospitals, partners, and payers. And at St. Pat's, he has oversight and accountability for ambulatory clinical programs in this region, as well as the integration of administrative and medical staff teams. And he works to strengthen and build on the relationships between St. Pat's and its other partners, Providence Medical Group, Providence St. Joseph Medical Center, and the medical staffs of Western Montana's acute care facilities. So he's also been focused on executive physician leadership. He completed his residency at the University of Colorado, Doctor of Medicine from the University of Illinois, Master of Science from the Chicago Medical School, and a Bachelor of Science from the University of California at Davis. Our next speaker, the one who made Samer go first, is Dr. Dean French. Dean, also your chair is on top of your laptop. You might want to fix that there. Oh, all part of the plan. Dean is president and CEO of Community Medical Center. He is a board-certified family physician, got his Bachelor of Science in Microbiology from the University of Arizona, and his MD from the University of Washington School of Medicine. Dean has deep roots in Montana. His wife, Jen, was born here. 2 of their 4 kids were born at Community Medical Center. He began his career with the Clark Fork Valley Hospital in Plains. His family practice was in Thompson Falls, and he served Plains as medical director for many years. He also was chief operations and chief medical officer at Mission Trail Baptist Hospital in San Antonio. He was the CEO of the RCCH Healthcare Partners facility in Sierra Vista, Arizona. And upon building a new medical center there, RCCH and Billings Clinic asked him to come back to Montana as CEO of Community Medical Center. He is a member of the American College of Healthcare Executives, American College of Physician Executives, he's got a lot of memberships, American Academy of Family Physicians. He also spent 7 years in the U.S. Army Special Forces and 2 years in the Army Special Forces Reserve. So everybody behave today. So please join me in welcoming our first speaker, Dr. Samer Khodor.
Hello, everybody. Thanks for having me. It's a pleasure to be here. I'm new to this community, and it's really been a very welcoming place for me and my family, so thank you. I know this doesn't look like the sexiest topic, but especially when you hear something really innovative and other things, but hopefully this is something that's important to all of us here. So I know the format is we present, and then there's some discussion, and something called civil discourse, which I actually have an appointment right when that starts, so I might have to step out when there's actual civil discourse. But anyway, how many of you have heard of social determinants of health? Just curious. Okay, so it's become more commonly discussed, which is a good thing. And I'm going to ask you something that, of all the things, all the factors that determine your health and well-being, how much of that is due to healthcare? What percentage would you give as healthcare playing that role? Just shout it out. 20. Anything else? 7. Wow. Anything else? Good question, but how we would consider healthcare, like going to your doctor and the infrastructure around healthcare, being seen in the clinic, having access to your provider, et cetera. Just what people really talk about now is healthcare. So I heard 7, 20, anything else? 50, okay. 1, okay, all over the place, yeah. I saw this a few years ago, and I was honestly shocked by it because, as an internist, I've been in private practice, I've worked at Kaiser, all these things. I thought I would have a better grasp of this, and I really didn't. And actually, all the physicians in the room were saying, is this true? And so since then, I've really been learning more and more about it. But anyway, let's go to the next slide. So I know we only have 15 minutes, and I want to, I have a full half hour now, okay? Okay, the last one, there we go. Okay, so here it is. Here's your health and well-being in the middle, and here are all the factors that influence that. So let's go around. So genetics, we have genetic predisposition. We talk about future of medicine and genetic testing. We've certainly done a better job of targeting therapies and improving diagnostic tests and other things. It's great, but remember, these are all interdependent too. So some may not have the resources to get these tests or to get the therapy, or don't have a provider, or don't have the money to see them, or choose not to, right? We know that that's another factor. So we have cures now from vaccines to HIV, where we know how to either prevent, delay, or treat some of these diseases. And people say, no, thank you. Or they can't have access to it or can't afford it. So again, genetics is exciting and certainly where we need to continue going forward. But again, there's all these very interdependent. Go to individual behavior. Again, the number one cause, or the main causes of premature death remain smoking, diet, and exercise. Okay, so if nothing else, by the end, we should realize that the future of medicine is going back to the basics. And that's really still the biggest area. The other is social and environmental factors, and we're going to talk about these. I focus this because this, as a community, this is an area we could really impact. We've relied a lot on healthcare to educate us about the other areas, right? And so how are we supposed to know that really smoking can kill us? Well, over time, we still have these conversations with our patients, despite the fact that we know a lot of them it's very hard to quit, but we have to have these discussions and really try to help them. So those are the areas there, again, interdependent. But if you take individual behavior and social environmental factors alone, that's 60% right there. So that's a pretty significant chunk. So there's a lot of discussion on healthcare. There's no doubt healthcare delivery and access needs to improve, and there's a lot of effort on that. But it is not the only conversation. And if you look at social environmental factors, in the US, we spend the most on healthcare. We also spend a disproportionately lesser amount on social services than we do healthcare. So whereas other developed countries said, these things play a role. You know, if you don't have a place to live or you can't find your next meal, you're not really going to care about your hemoglobin A1C that month or whatever it is. You know, there's priorities, Maslow's hierarchy in terms of what you need as a human being to be well. And so those are some of the areas that we are starting to look more at, really more social infrastructure for this. And so I'm going to show you some things in Missoula to see how we're doing. Any questions on this? Okay. Next slide, please. Okay, so here are the social determinants of health. There's a lot of things. So again, those are the big headings: economic stability, neighborhood, physical environment, education, food, community support, and social context. That's a tough one because how do you define that? You know, subjectivity is important, you know, your perception of it. But, you know, some people aren't isolated, but they feel isolated. Others really, you know, in the converse. So this is a harder one to get objective. And as a physician, we really want to try to get objective things. And some of these are really hard. A healthcare system, all those from availability of providers to healthcare coverage and all those. So there's a lot of headings here. Obviously, we can't discuss all these. So I said, how are we doing in Missoula on these? And I was actually pleasantly surprised. This is all from the Kaiser Family Foundation, by the way. So if you're interested, there's a lot more information. And you could, there's different priorities in these, right? And they are interdependent, and that's the key there. I think these are all interdependent. So next slide. So this is how we're doing in Missoula. And I know this is a lot of data, so I want to highlight the areas, really, that we should talk about. So I just took some of those from the social determinants from the previous one. So employment was an important one, housing, education, food environment, and I'll explain those, how we're doing with insurance and primary care physicians. I also added mental health providers. I think that is an area. Missoula, actually, we do pretty well here, but there's still a lot of opportunity. But if you look around other communities where I came from, actually in Colorado, within Kaiser, was not nearly as robust as what we have in this community. And so it's just something to observe. So unemployment, again, here we're doing pretty good compared to Montana and top U.S. performers. The green is good. Red is areas of opportunity, so strengths and weaknesses of the community. Housing problem is any problems with finding affordable housing or housing with plumbing and electricity and other things. They really break it down, so it could include other things. They didn't specifically mention homelessness, but you could imagine, you know, with having actually running water and electricity, if anyone has a problem with that, that would be captured there. And if you see just off the, you know, on all these, Missoula does well in 4 categories, really has one opportunity, which is housing, and the others are sort of right in the middle, just not seen as an area of real weakness or opportunity compared to other areas. This is from, let's see, I have it written, but anyway, it's counties, ratecounties.com or something. I'll get you that info. Hold on. I want to provide this because I think it's actually really helpful, and if you ever on there, you could, let's see, countyhealthrankings.org, countyhealthrankings.org. And you could compare different counties in Montana or different states or whatever. But anyway, so I mentioned housing. Education, we do better, both high school grads and some college, again, than other areas. So that's really good. Food environment, 0 is worst, 10 is best. This is not only access to foods, but access to healthy foods. So any of those. So did better than I thought, honestly, in some of these areas. That's the score there. Uninsured, again, we've gotten a lot better because of the Affordable Care Act and all the Medicaid expansion in Montana, which could go away and that could look different. So that's an important thing to note. And overall, we're still below the rest of the country on average. So even though Montana's done a lot better, overall Montana still has more uninsured than U.S. average. There it just shows a U.S. top performer, but on the chart of averages, it is lower. Primary care physicians, again, this is access to a primary care physician. That's an issue. Again, doing actually pretty well there. Much better than overall Montana, but not bad when you look at all around. And again, mental health, that's where we are. This is population per provider. So that's the ratio there. So for every 1,070 people, we have a primary care provider. And obviously, this is this is for Missoula County. So if you look elsewhere, they might not be as good. And you could see where Montana does in general. Any questions on that? Okay, next one. So then I took the other area, which is really important, health behaviors, and how are we doing there? Again, smoking, diet, exercise, number one, the top reasons, I'll say, for premature death. And when you look at that, and that is, how are we doing with adult smoking? We're in the red there, meaning an area of opportunity. Note that it's not just the number, but the trend. Okay, so when you look at, let's see, obesity, 22%, that's better than Montana or top U.S. performers. We have better, lower obesity here. But the trend here is alarming in where it's going and how fast it's going up. So that's why that's an area of opportunity. Obesity, as mentioned, excessive drinking, and I actually read this one, it's pretty funny, about how they classify excessive drinking. Anyone else curious or no? So it was like binge drinking, and more than 4 drinks for females, more than 5 for males, and per hour. No, so they had. It's interesting. You could see all the rates, but anyway, they used a standard formula for everybody, but you could certainly challenge how they did it. But so that's another area, excessive drinking, and being a college town. Again, it's not just binge, but ongoing daily sort of intake, and how much is that? Physical inactivity and access to exercise opportunities. They really have some good data in terms of how they capture this. It's how close you are to a trail or facilities, other things. Some might argue in Missoula County, at least I've heard, that access is tough in some neighborhoods. So this, again, looking at all Missoula. So if you're in one neighborhood, you might say, I don't believe that. Or I have a gym right next door that I can't afford, and I can't get out the rest of the time because of smoke or cold. So there's a lot of limitations there. But so those are the areas really of so what do we take from this? So we still, let's go back to the first slide. So, one more. So when we look at this again, we see that we're still having excessive, we have smoking. We have behaviors like we saw obesity being one of the factors, which is, of course, guided by diet, exercise, so that still continues. We saw that housing being a major opportunity in Missoula. I think we've seen that, but there's people really, especially when you look at, I didn't put that data, but for the average income for Missoula and what the cost of housing is, there's really a big gap. And so there's a lot of people out there that might come in and see a physician that are worried about paying their rent that month or finding a housing that actually fits their whole family, or better yet, a neighborhood that actually has decent schools for their kids, which again starts that whole cycle again of how we're doing, because all those things matter. And it's really hard to break that cycle once you're in it. You have, once you have poverty, low education, and really to break out and have the kids have the same opportunities is very hard. And that's what we want to do, right? Provide our future generations with better opportunities than what we had. So, did I use the whole half hour? I need to keep going? I need to talk about something else. Anyway, so that is really what I wanted to say. I think that of all the things that we talk about, the future of healthcare to me is going back to the basics, and really it needs to have more improvement of the physician patient relationship when we talk specifically healthcare, so I don't want to elude that conversation either. There's a lot of things happening around healthcare in the country and those things, and really the organizations understand how important that is. And so how do you improve care to the individual, the care to the community, and do it at a reduced cost? There's more and more ownership being placed really to everyone. So us as patients, we have accountability to do the things that we need to do. There's patients I had that just wanted to take a pill. It was easier than addressing a lot of the other, it was easier to just take a couple, 3 blood pressure pills than to actually get 20 minutes of exercise 3 days a week. So again, we need to modify that too, so that we're all really accountable. And it is a cycle. It's not just one item. So that's all I had. I guess you guys are going to talk and then come up with a question. Okay. All right. Thank you.
Thank you, Samer. I have nothing to add. No. I don't know when Susan called me and said, hey, do you mind talking to the City Club? And of course, whenever Susan calls, you just say yes. You all probably know that in this room. Just saves you lots of grief. And then the topic, I don't know if she told me quite then, but then it kind of trickled into my gray cells at some point, what is it? The changing landscape of healthcare. So when you do public speaking, it's like, okay, first of all, know your topic. And I'm not sure I know what the changing landscape of healthcare means, because it could be a lot of different things. And second of all, know your audience. Okay, so I'm striking out in all areas here. Actually, though, we did not conspire. But there is some piggybacking. I also don't have a PowerPoint. There is one over here that I'm staring at, but you don't get to see it. For lots of different reasons, mostly based on technology. So as I was thinking about this amorphous topic of the changing healthcare landscape, I started just sort of, it was pretty stream of consciousness, and it may have kept me up all night. But the first thing to think about is, well, what inherently is fundamental in our world? I run a bricks and mortar acute care hospital. That's my primary function in life. It's pretty straightforward. Patients come in, they say, heal me, don't hurt me, and be nice to me. That's it. It's that simple. And how do we do that every day? And believe me, it's a challenging thing to do every day. So there's a focus there in our world of just running a hospital that's there. But when you step back from it and you say, how are we doing in western Montana? Samer showed some really interesting statistics, but there's some more I'll share with you. This part of the country does pretty much better than anywhere else in the country when it comes to end-of-life care. We have the lowest number of people who spend some time in their last 6 months of life in an ICU here than just about anywhere else in the United States. The number one cost of healthcare right now is the last 6 months of life. And if you look at a rank order of every geographic region in the country, and you get to Missoula's MMR, which is basically from the Canadian border down to Salmon, Idaho, that stretch of 93, we're in the bottom quintile, meaning we spend less money in the last 6 months of life than just about everywhere else in the country. And if you look at the medical intensity of care, what we do as people get onto the end stages of life in our hospitals, it probably comes as no surprise that New York, New Jersey, Connecticut, they're way up at the top. And way down at the bottom is Washington, Idaho, Montana. So I could posit a whole bunch of reasons why, but first of all, it's not unintentional, and it's not just a function of geography and lack of resources, because truthfully, we don't actually have a lack of resources, at least in healthcare, as Samer just started to allude to. Part of it is back in the late 90s, this community was a leader, and I'm talking about Missoula, and many of you in this room know this, at end-of-life decision-making, and getting people's wishes encapsulated, talked about, and registered in a place where when I was sitting as a family doc in Plains and I had a patient roll over in a car accident on the perma curves on Highway 200, I could go on a registry and find out what their end of care wishes were, and that was like 2000, and we were way ahead of the rest of the country at the time. And lots of intentional effort around palliative care and around hospice. And what that does is it drives people out of the hospital setting, which is remarkably expensive, and into a setting that's far more compassionate and appropriate for that time. So that's one of the interesting things about Western Montana that I don't think is always well known. Another thing is, how are we doing on healthcare services in general? I can tell you that when I first came to this community in 1998, it was remarkable to me the level and sophistication of medical services in Missoula, Montana. I had come from UCLA, Ventura County, where I did my residency, and I can tell you that the level of services in Santa Barbara and Ventura, California were less than Missoula by a lot. So we had the International Heart Institute, we had Carlos Duran, and all the things that came from that effort. A sophisticated trauma program. I see Brad's lovely spouse here. So many things that were in place here that all over the country to this day you can find communities of Missoula's size that don't have it anywhere close to what we have here. And that legacy hasn't really changed. I think we have 3, it might be 4, cardiologists over at IHI right now that do a procedure called TAVRs. My last 4 communities I was in, which all had big heart programs, nobody did TAVRs. Nobody did them. So we've always been somewhere down the road. We have 15% higher number of surgeons per population than the rest of the country. We have, as you just saw on some data, just about where everybody, national top performers are on primary care. We are short what I call ologists. Everybody know what ologists are? Those are medical specialists. So neurologists, pulmonologists, gastroenterologists. That's where we run about 11% behind the rest of the country in terms of physicians locally available. But by and large, we've got a pretty robust healthcare system here. And it's reflected in some of our statistics. And now that my laptop has died, I really have no idea where I'm going from here. I said it was part of the plan. So what else is going on in Missoula, and what makes this? Like I said, you should know your audience. Good luck, Dean. We actually have a remarkably diverse economy. We didn't used to, right? But over the last 10, 15 years, the economy of Missoula has diversified markedly. And that provides foundational elements that are going to make the community stronger, and it's going to improve the social determinants of health over a long time. We have to solve our housing problem. Absolutely. That is impacting us on so many levels, including just basic things for employers like St. Pat's, like community. How do we get qualified doctors, nurses, technicians, social workers to decide to choose here rather than somewhere else? And housing is an issue. But it's also an issue for every aspect of the community. Another positive is we have Medicaid expansion. Yes, I said it out loud. So what wasn't true in Sammer's slides, and it's only because they're about 2 years, the Kaiser information is about 2.5 years old, is the rate of patients without any kind of insurance. So when I practiced in Thompson Falls, 27% of my patients walked in the door with no means to pay. And we were incredibly creative. And we always had to make really hard decisions about what the right thing to do was. It is not a position you ever want to be in as a physician. Right now, for my hospital, our self-pay rate is 0.8%. I didn't think I'd ever see that. The bad news is Medicaid expansion sunsets in June of 2019. That's a red letter day. It's marked on my calendar. And when we think strategically about what we need to do as healthcare providers and where we need to go, understanding what's going to happen with Medicaid expansion is huge. Other things, the University of Montana, an entrepreneurial climate, the Blackstone Launchpad, all of those things contribute to our ability in Missoula to think differently about healthcare, about how we tackle social determinants of health. These are all the positive things that are in the box. The other thing, and I'm going to pitch it because I don't think we do it enough, is something called WWAMI. And yes, I'm biased. I'm a WWAMI graduate, as is a third of my medical staff. And I bet the same is true at St. Pat's. And it is the unrecognized fuel. And it's interesting, when you look at some of those things I was talking about, end-of-life care, cost of care at the end, it's interesting how aligned the WWAMI states are. And that's not a coincidence. Medicine is cultural. If anybody tells you differently, they're full of it. I can tell you that the medical culture in Arizona, where I came from before I got back to Montana, thank God, is very, very different. And they're way at the top of the list when it comes to spending money at the end of life. And part of that positive culture in this community is the influence of the University of Washington School of Medicine and the WWAMI program and the leaders here in Montana of the WWAMI program. And I hear people say, we need a medical school for Montana. I will tell you, you have a top 10 medical school for Montana right now, and we need to make sure we're paying attention to it because the last 2 biennials, it's been on the chopping block. That's my political pitch. There may be more. So that's all the good news. What are our challenges? I started writing this list yesterday and decided that if I really gave it all to you, it would really be not a very positive experience. So I'm going to try not to do that. But there are challenges. One of our challenges in Montana is that we are actually a very small population. So I practiced and ran 2 hospitals actually in San Antonio, Texas. San Antonio's metro area is 2.5 million and their greater metro area is 4 million people. We had 11 acute care hospitals. Montana is 1.1, 1.2 million, spread out over the size of the state of California. We have 9 acute care PPS hospitals, big hospitals, and almost 60 critical access hospitals. That's a lot of resources for 1.2 million people. The problem is they're spread out all over God's green earth, which is burning down right now, but that's... And so it makes it very difficult to create sustainable medical platforms. You know, one of the reasons we have an ologist issue is it is very difficult in this environment for ologists to actually earn a living commensurate with what they think they should be earning from where they graduated in some large metro area. When they get here, you've got to go out and pound the pavement. Right? I met Mark Channer in Plains, Montana, because he was willing to come up there and do total joint replacements in Plains. That was when he was starting his practice. Right? You've got to be able to go out there and meet family docs in little far-flung places like, you know, Libby, Deer Lodge, all over the place. If you're going to be a successful ologist in Missoula, Montana, the population here doesn't support those specialists. It's just not big enough. And so how do we tackle that issue? The other issue is we've been in this big arc in the United States on something called moving away from fee-for-service and fee-for-value in the hospital industry. Has anybody heard this before? So-called value-based purchasing. And the challenge with that arc, and I unfortunately was at the tip of the spear on it back in 2011 when I was the founder of the first accountable care organization in Texas. And I practically bankrupted the Baptist health system with it. It's my claim to fame. Because we were way out ahead of ourselves on the concept of how do we keep people out of hospitals? How do we create rational care? And we were successful. The problem is there was no payment mechanism to support our success. And so all this bricks and mortar that we had, 1,100-bed hospital system in the city of San Antonio, we didn't have patients coming in the door because we were a victim of our own success. And there was not adequate financing in the system to do that. And so we rapidly, and I mean rapidly, got entrepreneurial. How do we get more people coming to our bricks and mortar? And that's the dichotomy we're still in. It hasn't changed. And it leads me to a place where the beauty of Missoula is if we're going to change what Samer presented with the social determinants of health, we have to coalesce as a community because the hospitals themselves as brick and mortar acute care hospitals aren't going to be able to do it without the help and the collaboration with a whole bunch of community enterprises. It just doesn't work. Susan knows this well. We have a frighteningly high suicide rate. We have a fragmented behavioral health system. We have competition and duplication of service lines. We have a complex regulatory environment. That would be the understatement of the day. And we also have a changing landscape of medical practice. When I saw that earlier today, I didn't remember what I was talking about. What I'm really talking about is we've had some generational changes. So when Walt was practicing, when Brad started practicing, you know, that generation of physicians was focused on their profession, their career, and the concept of doing call was no big deal. And I'm not just picking on the docs. This is across the spectrum. And I'm not sure it's an unhealthy thing. We get highly qualified medical professionals graduating from schools all over the country right now, but they have their focus and their priorities differently. And so now people knock on my door and they expect to get paid this, that they're seeing their profession, but those things called call and coverage and that you get looked at like you're kidding, right? You want us to do what? I got to go mountain bike, right? I got to go ski. I didn't decide to go into the medical profession so I could work all the time. And so we have to figure that out. But it is driving our cost curve. So what are the opportunities that we have right now? One opportunity is how do we leverage telemedicine? And particularly, how do we leverage telemedicine on those ologists? You know, if you think about the medical specialties, I ask my medical staff this all the time, do you need somebody that has tactile skills, meaning procedural skills, or do you need somebody with cognitive skills? And how do we bring the best and the brightest when we need them to the bedside, but we don't have to supply them bricks and mortar office, housing, and all these things 24/7, 7 days a week. But when we need them and when we need their expertise, we can bring them to the bedside, and our medical staff, our local medical staff, can benefit from that expertise. How do we leverage that? And I can tell you there's a lot of resistance because people are a little frightened of that concept. Does that mean I'm going to be out of work? And I think one of the things that we've been talking about is, well, how do we take some of our experts that we happen to enjoy in this community and export them on telemedicine platforms? We have to have a relentless focus on high reliability. And that was the heal me, don't hurt me, be nice to me. The don't hurt me part is only happening if we consistently do the same thing the same way. I worked in a hospital in San Antonio where they were not consistent in the care of the septic patient. And over a year and a half, lots of vigorous debates with ER docs, with ICU docs, with hospital medicine docs about high reliability when it came to early identification of sepsis patients. And yes, it's okay if a nurse identifies that they might be septic. And yes, it's okay if a nurse immediately starts some things. And we watched in the course of a year 120 lives saved compared to the year before because of high reliability. That means every time doing things the same way and creating processes of care that you never deviate from. The hard part about that, and I think it's harder in Montana, has anybody noticed that physicians in Montana tend to be a little bit independent? So, you know, one of our challenges in Samer's world and my world is how do we get these iconoclasts to say, yeah, I get it. I'm on board. I'm going to lead the effort. It's a challenging thing. I'm done. Okay.
I didn't say that. I said you have to wind up.
So I'll stop talking about the opportunities. So a couple things. The political climate in state budget right now is really interesting. I don't know how many of you paid attention to the biennial. I did. There were 79 healthcare bills. And the dominant message is healthcare is too expensive, which is really interesting because when you look at the statistics, We spend, we're in the bottom quintile, bottom 5th percentile of Medicare spending per beneficiary in the country. Source for that is the Dartmouth Atlas. If any of you haven't ever been there, it's worth going on. Bottom on Medicare spending per beneficiary. And yet out there in the public and with our state legislatures, the perception is we're way too expensive. And some of that perception is because of the changing nature of the health insurance world. My employees complain to me all day long about what? High deductible health savings accounts. How many employers are on those now? And what we're really seeing is a shift from the 80s and 90s where your employee-based health insurance had a deductible of $500 a year and then everything was paid for, to now deductibles of $5,000 to $10,000 a year, depending on what insurance and whether you have a family on it or not. And then the insurance company starts picking up 80-20. That's why they're screaming. The costs as compared to the rate of inflation have actually started to flatten. And they flattened more with Medicaid expansion, but we're not seeing the benefits of it quite yet. You started to this year with the 3 health co-op, the 3 ACA exchange products actually didn't rise as much as they did the year before. That's the result of Medicaid expansion. When you don't have people, when I said I had 27% of my patients in Thompson Falls without health insurance, what happens when you suddenly give them health insurance? They use it. There's this bolus effect that occurs. Now I'm done.
Now I'm serious.
Okay, I'm done. That's all.
Okay, thank you both very, very much. All right, so we're going to break. Please introduce yourselves to the folks at your table. We're going to take less than 10 minutes for you to formulate a question because some people can't respect time limits. And then we'll reconvene, and John will, each table, I think we can get it done pretty quickly so that we can get you out of here on time. So see you in a few minutes. Okay. We have John Rettenmeyer to finish up. Got your questions ready? Yes? Yes? Well, quit chatting real estate, Dave, and get your question together. Okay, John? Nobody has a question? Whoops, sorry.
I think we actually have one here.
Okay, all right, listen up.
Well, our table really we didn't have a question that we needed to talk about, but we did have a little discussion about private pay versus or the health savings account. Mostly I wanted to announce that on Monday night at the Roxy Theater at 7 o'clock. What? I just wanted to talk about Now is the Time. It's a movie about Medicare for All, and I just wanted to give everybody a chance to see it. So I didn't know what the question was.
You have a question?
We have a question. Since Congress is once again talking about possibly repealing the Affordable Care Act, and we know that the Affordable Care Act is more than just insurance for everybody, it means a lot of changes for hospitals. What changes would repeal make for both of your hospitals?
This is a long one.
It's a very simple question. 70+% of the Affordable Care Act was it was basically the Health and Human Services Secretary's discretion to make rules. And so with Dr. Tom Rice coming on board, he has the ability under the ACA to actually dramatically change ACA. How much he's going to do that is unclear. He's done some things already. One of the things they just recently announced, I think 2 weeks ago, is that they've changed Medicare payment schedules for outpatient total joint replacement. And that's a drive to allow total joints to happen in ambulatory surgery centers instead of hospitals. On its face, it's a cost savings measure and it actually makes some sense, to be honest. On the other side, if you're running a hospital, it's one of the few service lines that actually pays for itself. So Medicare pays for itself. So it remains to be seen, but the one thing I would say is most of the healthcare reform that we've actually seen started in 2008, actually, interestingly, with the stimulus, the American Reinvestment Act of 2008, is where most of the changes that we've been dealing with in healthcare actually started, and we don't think those are being affected by any of this. It's because those were passed as law. So they'd have to go to Congress to change it. So all the things about fee for service and versus fee for value and measuring outcomes and paying us for better outcomes, those things were actually in that law. They were in ERA High Tech, which was passed in 2008. They were not in the ACA.
Yeah, the big question for me is why are these decisions being made without more input from physicians, patients, healthcare delivery organizations, and this is really where it needs to go. We've always been on the reactive end of a lot of these changes, and I know there's a lot of pros and cons of big corporate healthcare, but that is one of the big advantages of organizations that Kaiser, Providence, Ascension, other big organizations have more ability to go to legislature and change some of that conversations, because I know there could be various I guess motives, but these organizations really are the ones that are, delivering the healthcare, and they need to be included on this. And they have not only physician but patient representation in terms of making those decisions, be more proactive rather than reactive to all this.
Thank you for your presentations. Given the complexity of this whole issue of healthcare, I think we would like to hear from each of you what 2 or 3 things could move the needle in the way we all want it to go, whether it's cost or healthiness. 3 things, whether it's legislative, regulatory, or some kind of other effort on a community or national or state level. Could you just say what would be the priorities? Specifically
Healthcare, just the healthcare part, right? For me, it needs more oversight. I know there's a lot of debate, and I know that it could be a political stance, but honestly, right now, everybody, we discussed this a little bit, right now there's just too many players in the game, and they all look at it from their perspective. It's not a patient-centered, patient-focused approach. And that's where, it can't be the EMR company, the electronic health record company weighing in. Then you have the insurers, then you have pharmaceutical, then you have the different organizations that deliver healthcare. So there's just too many factions, and everybody's looking at it from their perspective to stay alive and basically stay in business. So I think I would just narrow it down to one. It really needs more oversight, and that's the difference between healthcare in the U.S. and healthcare in developed countries. So you've seen those charts, and I didn't bring those, but how much more we spend on healthcare, and we have amongst the worst outcomes. Where we excel, as Dean kind of alluded to, is acute care. We're really good if in the last bits of your life, or if you're really, really sick, we can rescue you. So it's really been a rescue system. We've done very little in terms of proactive healthcare, and I'm not just talking about the social determinants and others, but really about preventive medicine. So we're, population health. You heard Dean's example. You create an ACO, you keep patients in the community healthy. What happens? Well, you go out of business. So they have to be aligned, and we can't change that in healthcare. I would love to make that happen, and we've invested a lot in, as has Dean's organization, in terms of being more population health, preventive centered. But in the end, we have not gotten ROI on any of this stuff. So while we believe it as physicians, as really trying to be leaders in healthcare, it's not a sustainable process the way it is.
I'll flesh out Sammer's word oversight and tell you to go see that film at the Roxy.
Yes, my question is, how would your organizations respond to a single-payer system similar to Germany and Japan?
It would simplify my world greatly. So we all hate Medicare, right? Because it's bureaucracy. There's a million rules. But the reality is, I would prefer to have one entity I'm dealing with and learn their bureaucracy and their rules. Plus, If you look at the track record of Medicare from 1967, 68, when it first came online with the Johnson administration till now, its administrative cost, adjusted for inflation, over that entire swath of time has never gone over 8%, and it's generally hovered around 6%. The commercial insurance industry, whether it's not-for-profit or for-profit, has always had administrative charges in excess of 20%. And this concept that if you have more insurance providers, that creates some sort of competition, I would challenge you to ask, what is the product? What is the commodity that they're selling? It doesn't exist. And all you're doing is taking away economies of scale by having all these duplicative actuarials, people managing accounts. And that reason why Medicare administrative costs are low is because they have a huge population in largely one administrative system. So yes, would my world get more complex? Would we be arguing with our state, our local elected leaders, Senator Tester, et cetera, to raise our Medicare rates? Of course we will. But we'll also figure out how to lower costs.
So, I want to even think bigger, because our one lever we always pull is by payment. So our whole healthcare structure has been by payment, and specifically, what will we not pay for? Versus let's focus on really delivery and what we're trying to achieve. And again, that's not just healthcare, but these other things. Individual healthcare systems are looking at that. When we look at our patients here in Missoula and our high utilizers, those that are healthy, where can we really impact that and change how they get their care, not just what we will or won't pay for. We deliver a lot of care that is zero compensated. We have negative budgets in a lot of departments, but we know we're doing the right thing because we don't want these patients to show up in the ER or in the hospital where, guess what, that's where we get reimbursed. So again, it's not a sustainable model for our organization or the whole healthcare system. So we need to spend less time on payment and look really on care delivery would be my hope for the future.
So my question stems from the comparisons we tend to do when we're talking about healthcare, and more specifically, if we're doing better than the rest of the country, we're doing good, which doesn't make sense to me a whole lot. And more specifically, when we're talking about primary physicians, which was, I think, 1,070 people to one provider, is that really good, or is that just that we're doing better than everybody else? That's really good.
It's actually really good, and Dean alluded to, you need a certain population to, I don't know what the word, justify that, to just somebody to be busy enough. And there's a happy medium, right? You can't go too many, but to stay in business and to be sustainable, and, you need a certain amount of population. That's where Dean was alluding to, if you're a cardiothoracic surgeon and you want to practice in planes, you need that volume, essentially. I used an extreme example. But you're right, you shouldn't just look how the rest of the country is doing, but what can we do to do better? And I think we look internally at our organizations, we continue to try to raise the bar in terms of our metrics of where we need to be, not necessarily we're doing really well here. But in general, some of these is driven by a lot of factors, as we mentioned. So recruiting, not just physicians, but staff is a challenge here. They see the cost of living, they see a lot of things, it's really hard. So this, you need outstanding nurses and other staff to take care of the patients, not just the physicians, and getting those and keeping them here is really challenging.
Hi, I'm a client. I think it's great that Missoula, Montana is innovative in a lot of different areas. We've heard about the current medical system, which is pretty much reactive in many, many cases. So the proactive part is, I think, is the lowest hanging fruit. So, and I think I tried to send you gentlemen emails about a Missoula native, Dr. Leroy Hood, who's the Chief Scientific Officer for Providence, and his P4 program, which I had the opportunity to talk to him about recently. Can either of you comment on that and maybe explain it a little bit from your viewpoint?
So essentially, it's this concept of really studying the genetic determinants and then having an aggressive program where we're meeting people and really sort of mapping out their healthcare decisions and choices based on what their DNA tells us. That's my understanding of it. If I'm wrong, you can certainly correct me, because I don't work for Providence, so yeah. So, but basically, it's this set of measurables, including your DNA, your blood tests, et cetera, and then you boil it all down and you say, you know, when Susan comes to me with high blood pressure, it doesn't make sense to put her on a beta blocker, because we know based on these tests that a beta blocker won't work for you. So why waste the time, energy, and effort, give you the side effects of that beta blocker? We should move right over to an ACE inhibitor. I mean, and then Walt would be happy, because everybody needs to be on ACE inhibitors, I believe. That's the promise of it. I got interviewed in 2010 or 11 in San Antonio on the front page of their medical rag that they put out. So I think just the doctors read it. And as a healthcare leader, which my wife found particularly entertaining at the time. And one of the things I talked about was, you know, the promise of this concept. And I had been, you know, thinking about it for about 5 years at that point. The problem we're having is that some of the technology and proof of concept isn't really there yet. Not to the extent that the FDA is going to say yes. The other problem, of course, is the non-sexy discussion of who's going to pay for it. Now, on its face, that argument makes no sense, because if people paid for it, it would lower the cost of healthcare. But that's the issue, is right now it would be completely a boutique. Those of us that are lucky enough to afford a house in Missoula could probably pay for it. But not everybody can, not under the current structure.
Yeah, I love everything about it in terms of as a patient or as a physician to have real evidence, as Dean alluded to. But again, remember the interdependence of all those other things. And we have, you know, diseases that we think we eliminated years ago with a simple vaccine, yet some either choose not to or don't have the access to or can't afford to get some of these things. So from that to, as I mentioned, HIV even, we have cures or near cures and other things, and there's still a lot of barriers to getting those. So while we need to continue forging forward in science and being more targeted, we've certainly done that. Probably oncology comes to mind as probably the most advanced field in terms of really always changing chemo and things according to targets and other cell receptors and things, and that's really exciting. But again, there's a lot of other factors there to consider, so it's an area we need to keep delving, but that it can't be just our only area of focus for the future.
So I think the only table we missed were the ones that who had direct access to the speakers. Anybody else have a question? Another question?
I think they asked about 12 questions.
Are you okay?
Did you guys come up with
We
one?
did. We had them all answered right away.
Yeah, y'all have done a great job.
All right then. Well, thank you all very much for being here. Thank you so much to our speakers and our sponsors. Next month, we are moving to the third Monday in October, because the second Monday is a holiday, and we will have a mayoral debate with Mayor John Engen and challenger Lisa Trepke. And then November 11, we back to our usual second Monday schedule with President Sheila Stearns. So we hope you'll come back, register, spread the word about City Club, and again, thank you to our speakers.